Hello everyone, myself Dr. Samir, and today I am going to discuss about a paper recently published in Critical Care Journal by Hay et al. Neostigmine for intra-abdominal hypertension in acute pancreatitis, a randomized controlled trial. So coming to IAH or intra-abdominal hypertension, according to World Society for Abdominal Compartment Syndrome, a persistent rise in intra-abdominal pressure of more than 12 millimeters of mercury is defined as intra-abdominal hypertension. Now, the intra-abdominal hypertension, that is a rise in IAP of more than 12 millimeters of mercury, is an early risk factor for development of severe acute pancreatitis. Now, there is an observational study of intra-abdominal pressure monitoring in acute pancreatitis, which was published in May in the Journal of Surgery. They found that in 17% of acute pancreatitis patient, there is incidence of intra-abdominal hypertension, and this results in a mortality of around 37%. Now, coming to the pathophysiology of intra-abdominal hypertension. So what happens in acute pancreatitis? There is pancreatic and visceral edema. Because of that, there is capillary leakage, and that leads to ascites, and there is gut injury, that leading to paralytic ileus, and this ileus leads to gastric dilatation, and as there is gastric dilatation, that results in a raised in intra-abdominal pressure. Now, intra-abdominal pressure, when it raises more than 20 millimeters mercury, it is called as abdominal compartment syndrome, and if a patient develops abdominal compartment syndrome, it leads to your organ failures. Because of the high IAP, there is reduced perfusion like in liver or maybe kidneys, or there may be AKI. There is a reduced organ perfusion that leads to organ failure, and thus results in a mortality of around 49% in case of severe acute pancreatitis. So the methods for treatment of this acute abdominal compartment syndrome is, it can be surgical or it can be non-surgical. Surgical is generally decompression is done. However, it is associated with a lot of morbidity. So there are non-surgical procedures that can be attempted or tried to reduce the ACS or the abdominal compartment syndrome. So the various methods that are generally used is nasogastric decompensation, pro-motility agents to increase the motility, and that leads to stool passage, may come down on the volume of the ileus will be relieved, the dilatation will be reduced, the pressure will be reduced, or there can be percutaneous catheter drainage. Now, World Society for ACS, they have suggested neostigmine in established colonic ileus that does not respond to simple measures. So these are the simple measures, the non-surgical measures, and it says it has suggested, although there are no specific evidences or studies that support the use of neostigmine. However, they have suggested as a good clinical practice that we can give neostigmine in established colonic ileus. Now, when is it called established colonic ileus? I'll come to that later. So coming to neostigmine first, it is the anticholinesterase. It causes enhanced intestinal peristalsis, thus promoting the passage of flat test and defecation that will reduce your intra-abdominal pressure. So effectively, it induces colonic decompression among the patients with colonic pseudo-obstruction. As we know, during mechanical obstruction, we should not give any prokinetic agents. So no evidence for use in raised IAP, IAH or ACS, as I told. It is just a suggestion from the World Congress for Abdominal Compartment Syndrome. So here I will tell you what is diagnosed colonic your obstruction. So paralytic ileus, as I told, is a common risk factor for IAH. Now, the colonic obstruction can only be diagnosed by an erect X-ray, which is difficult in cases of patients of acute pancreatitis when they are admitted in the ICU, or it can be done by CT abdomen. So when the patient is developing your high intra-abdominal pressure, going into intra-abdominal hypertension or abdominal compartment syndrome, that chances of organ failure, patient could be in shock. This type of patients are difficult to be shifted to your CT console for a CT abdomen, or they cannot, or maybe some may be in ventilator support. It will be difficult to shift them or difficult to go for an erect X-ray. So it is not possible in early IAH. So to evaluate the efficacy of neostigmine in reducing the intra-abdominal pressure in patients with acute pancreatitis and persistent IAH, so this was the rationale behind doing this study by Hay et al. So they plan to give this after 24 hours of conventional treatment that we discussed earlier, non-surgical. Now, irrespective of the diagnosis of colonic pseudo-obstruction by X-ray or CT, even though if it could be done, it was good and fine, or even if X-ray or CT could not be done and they are suspecting there is colonic pseudo-obstruction and not mechanical obstruction, that has led to the raise in IAP, or that has led to your intra-abdominal hypertension or abdominal compartment syndrome. So in those patients, they tried to use Neostigmine. So we shall see how did they go about the study. So methods, this was a single center, 2-armed parallel group superiority trial. It was a phase 2 trial which was conducted from September 2015 to August 2017, a period of 2 years, in pancreatic ICU of Nanchang University. So the eligibility of who could be enrolled in this study were that the age should be between 18 and 70 years. It should be within 2 weeks of onset of acute pancreatitis and diagnosed as IAH, intra-abdominal hypertension, during stay in pancreatic ICU. Now, as we know, IAH is IAP more than 12 millimeters of mercury after conventional treatment for 24 hours. That is a persistent increase in IAP over 12 mmHg is called IAH. So this has to be the inclusion criteria. Now coming to the exclusion criteria, there could be, if there is any laparotomy history, then those patients were excluded. If there is intra-abdominal bleeding, these patients were also excluded. Any contraindications to Neostigmine like angina, AMI, VT, bradycardia, asthma, mechanical obstruction, epilepsy, hypothyroidism, they were also excluded. Any UTI or previous bladder surgery, they were also excluded, or pregnancy and lactation. Bladder surgery because the IAP was measured by the bladder. I will come to that later. So IAP measurement, coming to, it was generally done, the process of IAP measurement, it was done in supine position. So 25 ml of sterile NS was injected to the bladder. Now the transducer was zeroed at the level where the mid-axillary line crosses the iliac crest. So in case of mechanical ventilated patients, it was done under sedation, and in case of awake patients, it was done under end expiration, at end expiration, so that there is no contractility of the abdominal muscles, so that doesn't affect your IAP measurement. Now the conventional treatment that was used, as I said, after 24 hours of conventional treatment, the patients were randomized. So conventional treatment was generally sedation, analgesia. Maybe patient was in a light plane of anesthesia, that is why there would be efforts from the patient to breathe, that could have raised in IAP raise. So sedation, analgesia, nasogastric decompression, glycerin enema, negative fluid balance, and maybe percutaneous drain for ascites. If it was because of fluid overload, then albumin laxatives, or if needed, RRT or renal replacement therapy was started. And there is a Chinese concoction that is called rhubarb, that was also given along with a salt. That was also tried in some patients, as there is a study that shows better results with rhubarb in reducing IAP. Okay, so these were the agents tried in first 24 hours, that is the conventional treatment, and then they were randomized. So randomization, it was a non-blinded study. The patient, the participants, the investigators, everyone knew about the allocation. So however, randomization was done by sealed envelope. It was 1:1 ratio. Neostigmine group, the protocol was intramuscular neostigmine of 1 mg every 12 hours. If no defecation after 12 hours, it was given 1 milligram every 8 hours. And if no defecation after 24 hours, it was given 1 milligram every 6 hours for 7 days. So they wanted to study the effect of neostigmine in the reduction of IAP at day 7. Now neostigmine stopped if IAP came below 12 millimeters of mercury. That was, there was no more evidence of IAH, intra-abdominal hypertension, then the neostigmine was stopped. Now enteral nutrition through nasojejunal tube was started if the IAP in the abdominal pressure was below 15 millimeters of mercury. So the protocol for starting EN was, it was started at 20 milliliter per hour and increased by 15 ml every 8 hours to the goal rate of 25 to 35 kilocalorie per kg per day. Enteral nutrition was stopped if IAP was more than or equal to 15 millimeters of mercury, and after then parenteral nutrition was initiated. So IAP of more than 25 millimeters of mercury or organ dysfunction or fulminant abdominal compartment syndrome, If any event such as this occurred, then there was a multidisciplinary meet between surgery team, gastro team, pancreatic team, and they decided for surgical decompression was taken by that team, whether to be go for surgical decompression or go for conservative maneuvers. And follow-up of this patient was done at 1 month, 3 months, and 6 months, either through OPD or by phone. So the outcomes that were measured were: primary was % change of IAP at 24 hours after randomization. As I told 2 slides before, that first they had planned for a % change of IAP at day 7. However, during interim analysis, they found that the most prominent effect of neostigmine was seen at after 24 hours. So they changed the primary outcome from % change of IAP at 7 days to % change of IAP at 24 hours after randomization. So IAP, although the clinical registry was done for % change of IAP at 7 days. Now IAP at 3 hours was measured after randomization, and then every 6 hours till 72 hours. If the patient was in ICU with IAP of more than 12 mm mercury, then it was measured every 6 hours. However, if the patient was shifted to ward because of being stable, it was measured every other day till 7 days. The secondary outcomes measured were stool volumes at 24 hours and 7 days after randomization, timing of the start of enteral nutrition, how early it was started or how late it was started, deterioration of intra-abdominal hypertension, new onset abdominal compartment syndrome, new onset organ failure, mortality for index hospital stay and within 6 months of follow-up, the mortality ratio, and other complications or adverse events and the costs on the patient that were also taken into account. So these are the outcome definition table for what they had the variables defined as per their study. So coming to the statistics, so sample size was calculated from the observational data or pilot study. That reduction of IAP by 30% compared to 5% in by conventional at 24 hours. So this was the difference of 25%. So with the power of 80%, alpha of 5%, and taking loss of 10%, sample size was calculated to be 14 each. So total 80 patients were to be taken in the study. Both intention to treat analysis and per protocol analysis was planned, and intention to treat subgroup analysis in case of patients with IAP more than 15 mmHg was planned. Students' T test was done for normal distribution. Kruskal Wallis H test was done in the absence of normal distribution. So coming to the results, so acute pancreatitis patients with IAH, that is more than 12 mm of mercury, they were screened for eligibility. Total it was 185. So 105 were excluded because they did not meet exclusion criteria in 36, refused to participate 21, and circulatory failure, arrhythmia 20, and other causes. So around 80 were randomized. So neostigmine group 40 and conventional treatment 40. It was 1:1 allocation. So number of hospital death was 7 in case of neostigmine group, and it was 8 in case of conventional treatment. So follow-up for 6 months, there were 33 follow-ups, and there were 3 deaths after discharge and lost to follow-up, and same in the 32 were followed up after 8th death, and 3 deaths after discharge and lost to follow-up. So now coming to intensity to treat analysis, baseline characteristics. So more or less all the parameters, they were not significantly different. Age, sex, the etiology of pancreatitis, biliary hypertriglyceridemia, alcohol excess, idiopathic. The most common cause of acute pancreatitis in the patients with hypertriglyceridemia. So onset to hospital admission, onset to randomization, comorbidity present in the patients of acute pancreatitis, all were comparable. Admissions, clinical severity like SIRS, SIRS score, Apache 2 score, CRP, TLC counts, procalcitonin, serum lactate, organ failure, single organ, be it respiratory, renal, or organ failure, combination of both, multiple organ failure. The CT severity score index within 1 week of AP onset, they were all similar in both the aspects, both the groups. There was no significant difference found. The IH level also grade 1, 2, 3, 4, there was no significant difference. Compartment syndrome also there was no significant difference. Use of opioids was 4 in your neostigmine group and 1 in your conventional group. Colonic ileus, there were 3 incidents of colonic ileus in neostigmine group and 0 in case of conventional group. 24-hour defecation volume, PCD of ascites, admitted to isolated randomization. So coming to IH level before randomization, it was similar in both the groups, grade 1, 2, 3, 4, the incidences were similar in both the groups. Abdominal compartment syndrome was similar and statistically is insignificant in both the groups, however lower in case of Neostigmine group. Use of opioids, it was 4 in case of your conventional group, whereas it was 1 in case of Neostigmine group. Colonic ileus was 0 in case of Neostigmine group, and 24-hour defecation ml was higher, that is 800 ml in case of Neostigmine group, however nothing were clinically significant. So before randomization, 38 patients, that is out of the 80, 47.5% had respiratory failure, and 48, that is 60%, 48 out of the 80 had IAP of more than 15 mm mercury, and 18.8% had abdominal compartment syndrome. So they were distributed as we saw here, IAH, WSACS, they were distributed as per this. So 4 in Neostigmine group and 1 in conventional group used the opioids. Neostigmine group 3 had colonic ileus, 1 in the opioid group. So before randomization, 38 patients out of the 80, that is 47.5%, had respiratory failure, and 60% had IAP of more than 15 millimeters of mercury, and 15% had abdominal compartment syndrome. Now 4 in the Neostigmine group and 1 in the conventional group used opioids. Neostigmine group 3 had colonic ileus, 1 used one of them used opioid, maybe because of that. The baseline parameters, as I said, were comparable. So Neostigmine group 33 received every 12 hours, 9 patients for 3 days, and 23 patients for 7 days. The IAP was reduced after randomization in both the groups. Okay, in the Neostigmine group also the IAP reduced, in the conventional treatment also the IAP reduced. However, the drop was significantly faster as assessed at multiple time points in the Neostigmine group. The drop was significant at 9 hours, at 15 hours, and at 168 hours. Now, subgroup analysis, as it was planned, of IAP more than 15 millimeters of mercury, mean IAP was significantly lower in Neostigmine group at 3 hours, at 9 hours, at 24 hours, at 30 hours, and at 168 hours. Now, per protocol analysis, so IAP at 15 hours was significantly lower, only at a single point, that is at the 15 hours. The primary outcome rate of decrease in IAP was significantly faster by 24 hours, median, and with 25 to 75 percentile, and P was 0.017, so that is a significant change. The rate of decrease was significantly faster in Neostigmine group. So this is intention to treat analysis, subgroup analysis at IAP more than 15, and per protocol analysis. So we can see that intention to treat analysis, the IAP was lower at 9 hours, 15 hours, and 168 hours. Subgroup analysis of IAP greater than 15, there we see that the IAP was significantly lower in Neostigmine group at 3 hours, 9 hours, 15 hours, 24 hours, 30 hours, and 168 hours. However, by per protocol analysis, the drop was significant only at 15 hours. So secondary outcomes, stool volumes was consistently higher in Neostigmine group, that was also significant. And however, the timing of enteral nutrition, the deterioration of IAH, new onset ACS, new onset organ failure, mortality 7/40 versus 8/40, follow up for 6 months, there was no significant difference. So this is the intention to treat plot of increased stool volume at 24 hours, that was definitely significant. Neostigmine group, the volume was quite higher on day 1, day 2, day 3, day 5, and day 7. So per protocol analysis, as I showed, there was no difference, only except at 15 hours. Now subgroup of analysis for baseline IAP more than 15 millimeters of mercury, stool volume above baseline at day 1 were higher, only at day 1, and remaining results there was not statistically significant. Okay, so subgroup analysis, 15 millimeters mercury, which was the subgroup, volume at day 1 was only higher. So worsening of intra-abdominal hypertension took place in 12 number of patients. 3 had intra-abdominal bleeding, out of which 2 hemostasis was achieved and 1 resulted in death. There were 5 fluid overload patients among these 12. So IAP was reduced in 1 after intervention. Rest 4 had more than 50% pancreatic necrosis. Out of those, only 1 survived. So intention to treat analysis of primary and secondary endpoints. So primary endpoint, it was significant as I told you already, with a p-value of 0.017. Rest all, there was no significant difference except increase in stool volume at 24 hours after randomization and increase in stool volume at 7 days after randomization. This was intention to treat analysis. Other parameters like intra-abdominal bleeding, intracutaneous fistula, septicemia, vascular complications, disease severity, death, length of stay, length of ICU stay, medical expenses, there was no significant difference between both the groups. Follow-up at 6 months also, no significant difference. Pancreatic pseudocyst, portal thrombosis, other complications, there was no significant difference in both the groups. Now coming to the subgroup analysis of primary endpoint and secondary endpoint, as I said, primary endpoint, it was significantly different even in case of subgroup analysis, and in case of subgroup analysis for secondary endpoint, only the increase in stool volume at 24 hours that was significant. Rest all, it was not significant. Now per protocol analysis of primary endpoint and secondary endpoints, again the percentage change of IAP at 24 hours was clinically significant in case of Neostigmine group. The increase in stool volume at 24 hours and day 7 in case of Neostigmine group was significantly higher. Rest all, there was no significant difference. So the adverse events in the patients, so we can see here 6 cases of adverse events, 5 in Neostigmine group, 1 in conventional group. So coming to that, 1 patient had bradycardia, 3 had circulatory failure, 4 had circulatory failure, 1 bradycardia, 1 respiratory failure. So unlikely it was all because of Neostigmine. New onset circulatory failure occurred in 3 patients in the Neostigmine group and 1 patient in the conventional group, given Neostigmine because of continuous increase in IAP. Okay, so this was mostly because of your severity of the acute pancreatitis. It was attributed to that and not because of the Neostigmine. So respiratory and or renal failure prior to randomization and circulatory failure was attributed to progression of acute pancreatitis. The one event of bradycardia, it was found to be associated with esmolol, as the patient who had developed bradycardia after Neostigmine, the patient was also receiving esmolol, and once the esmolol was withdrawn from the therapy, the heart rate returned to normal. So this bradycardia was also not attributed to Neostigmine. Now, 1 patient in the Neostigmine group developed new onset respiratory failure after rebound elevation in IAP leading to SCS. This was again attributed to your severity in your acute pancreatitis and was not attributed to Neostigmine use. So basically, overall, what we saw in this study was that Neostigmine treatment significantly was more effective than conventional treatment in reducing the IAP at 24 hours and also increasing the stool volume at 24 hours. So the reduction of IAP was seen, the change or not significant, but the reduction in IAP occurred within 3 hours of use of Neostigmine. So it was most pronounced at 15 hours, in the first 15 hours, and it was also significant as we saw at 24 hours, but the highest effect was seen at 24 hours, after which it faded. So it was more evident as we saw subgroup analysis, it was more evident in patients with severe IAP, that is of more than 15 millimeter mercury at baseline. So and reduced IAP, it appears relatively modest in Neostigmine group, and it is more severe and conventional use. Chinese herbs were used in those groups. As I told you earlier, this was a bias or a confounding factor because this was used in many patients in the conventional group. So, and this is used to be, it is thought to be a very good drug in reducing the IAP, as they already have a study also with this, that it is quite effective in reducing the IAP of the patients. So that is why there is relatively modest reduction in IAP in Neostigmine group compared to your conventional treatment group, because the conventional treatment use this Chinese herbs in most of the cases. So there is a dose dependent relationship between the IAP and organ dysfunction, and so the more the IAP, the more there is organ dysfunction because of reduced perfusion of the organs. So incidence of new organ failure and new onset respiratory failure, it was 2 of 40 versus 6 of 40. It was definitely reduced, although not significant. And renal, it was 0 versus 3, and overall organ failure was 12 versus 16. So it is definitely lower in case of Neostigmine group, however, it was not statistically significant. Now, increased stool, as we saw, it was significantly higher, increased stool volume in day 1, and in case of Neostigmine group. So this implies better motility, although it did not hasten the starting of enteral nutrition. But since ESICM says that enteral nutrition can be started with the IAP of less than 15, so that is why it should be enteral nutrition should be held when the IAP is more than 15. So better motility, more stool passage means there is a reduction in IAP, thus it may aid in your early enteral nutrition. So this study showed superior results in patients with IAP more than 15. So as ESICM says, to give enteral nutrition when IAP is more than 15. So that is why this Neostigmine should be helpful. That is what the authors think. Higher number of such patients in analysis may have led to insignificant starting time of enteral nutrition in both the groups, as both the patients had very high IAP. So maybe there was a delay in starting of enteral nutrition, but there are chances it could have developed. So Neostigmine had significant beneficial effects on IAP. That was what we saw in the study, and gut function indicative of an independent action that may be widely applicable to patients with acute pancreatitis and your intra-abdominal hypertension, or plus or minus with or without abdominal compartment syndrome. The limitations of the study were nobody was blinded, not even the participants, not the investigators, so they knew which group was going to where. The sample size was quite small, of around 40 patients in each group. There were crossover of 4 patients. They had to be given Neostigmine because of high IAP and what is not being controlled in the conventional group. So as they were not blinded, they knew. So they changed over. Then they was not adequately powered for the result. That started with reduction in IAP at day 7. However, during interim analysis, they found it at IAP is more significant at first day after 24 hours. So they changed the primary endpoint midway. So it was not adequately powered study. And also it was a phase 2 trial. So only efficacy, safety was seen. And it should be, phase 3 trial should be tried in this to aid the larger population for the benefits of Neostigmine. Thank you.